Monika Pathak will be talking whether to give. She will be against, I think, hormone therapy at 60 years.
Thank you, my opponent, Dr. Tabassum. You have made my things a little easier by yourself mentioning that why not to give, you have to individualize the patient. That is most important. I am here for MHT at the age of 60 years. Is it still the right choice? I am against this motion. I do acknowledge that MHT is most effective treatment for vasomotor symptoms. Benefits are real, proven, but what the guideline supports, it is for appropriately selected women. And I caution, at age 60 is a physiological inflection point. Vascular aging, accumulated comorbidities, and timing alter the benefit-risk equation fundamentally. So I oppose the routine universal MHT initiation at age 60 is not supported even by the many guidelines. The blanket prescribing is not the precision medicine. Age, timing, and individual risk, not symptoms alone, determine the appropriateness of MHT. The timing hypothesis, though we have got a window of opportunity, but as per the elite trials, it says no benefit in late group when the menopause is attained more than 10 years. Cochrane review, again 2015, HRT started more than 10 years of the menopause, it has got a neutral effect. And the cardiovascular and the survival benefits of MHT depends critically on timing, not just whether MHT is prescribed. Why age 60 matters? Because it is the physiological inflection point. Here the woman is already having arterial stiffness and endothelial dysfunction established. Atherosclerotic plaques already present in many. Estrogen loses its anti-atherogenic potential and the balanced cardiovascular disk risk doubles with each decade after 55. So pro-inflammatory state also escalates. So atherosclerosis is locked in long before at the age 60 and estrogen alone cannot reverse the established plaques. By the age of 60, 60% of women are already hypertensive, 40% obese, 55% has dyslipidemia, 30% are already diabetic, 25% subclinical cardiovascular disease. So each comorbidity potentiates the MHT risk. Starting MHT at age 60 means starting in an already altered milieu. Even the evidence from women health initiation and major trials, they have compared the age-specific outcomes and they have found that the coronary heart disease are having the high risk, stroke, elevated risk. Of course, VT is the risk is increased to 2 to 4 times. Mortality all causes almost neutral, but there is increased chances of breast cancer, increased chances of dementia in such patients. What are the risks associated with initiating MHT after 60? VT, DVTP, it has the 2 to 4 times risk is increased. Stroke, Cochrane 2015 has already mentioned that stroke risk is increased. Breast cancer chances are more. Coronary events, of course, there is no benefit on CHD benefit in late initiation group. As per the elite trials, the cognitive risk increases. Even the other risks, like gallbladder disease, ovarian cancer, endometrial cancer, of course, not in cases of progesterone, if not given adequately. Liver, of course, first bypass effect is got a benefit, but not the others. Now, what the major societies say? They say no routine use after 60. Even the British Menopause Society, NAMS, IMS, EMS, Endocrine, ACOG, FOXY, unanimous consensus has been already established that no scientific society recommends the routine MHT initiation for all women at age 60. Individualization is universal. So whenever a patient comes, women at the age of 60 or more than 60 with persistent VMS, first exclude non-menopausal cause. Give them the non-hormonal therapy first, like fezolinetant, SSRI, SNRI, CBT, gabapentin, lot of things are available. Only in cases when there is inadequate response, then you can fully individualize the risk assessment, and then only after the informed consent to patients with full benefit risk discussion, then only she should be offered FHT. An expanding therapeutic armamentarium is available like NK3 antagonist, SSRI, SNRI, gabapentin, CBT, lifestyle, local vaginal options. They are all available. Why not to use them first? Even the evidence-based reality, they have said that effectiveness does not equal universally appropriate prescribing. Penicillin, though it is effective, but not for everyone. The question is individual benefit risk, not population level efficacy. The ELITE trial shows no cardiovascular protection when MHT started later 10 years post menopause. Cochrane 2050, it shows neutral effect in late initiations. And IMS 2024 also states caution for new initiation after 60. So MHT is definitely effective, but effectiveness in selected women does not justify the routine prescribing for all women at age 60. The benefit-risk ratio of MHT changes fundamentally after age 60 or more than 10 years since menopause. No major scientific society recommends routine MHT initiation at age 60 for all women. Non-hormonal therapies should be offered first. And if MHT is considered after age 60, lowest effective dose and the transdermal, I agree to this. But the future of menopausal care is the precision medicine, tailored to each woman's age, timing, symptoms, risk, and preferences, not as a blanket protocol. At 60 years of age, the question is not whether MHT works, but the question is whom, when, how, and what risk. So menopause care must move from blanket prescription to precision medicine.
Thank you. Now just 1 minute each to argue the opponent. Then we will go to the other topic. Dr. Tabassum first. Just 1 minute.
I agree you're saying that all the problems are there, but if problem comes, that doesn't mean you don't have solutions. You want to give the best to your patient. So if one patient of 110 kgs comes to you, and then she has got a history of risk of VTE, and she's got swollen legs, would you tell her to abort her pregnancy? No, no. Then what are you going to do? You are going to manage her. So whatever problem is there, we have to understand the problem and manage it. That doesn't mean that you have to just not give things and you have to just abort the pregnancy. That is how it is here also. So any problem is there, you have to manage the problems and give the patient the best. So best for our 60-year-old young women.
Thank you, Dr. Monica. 1 minute.
Yes, you yourself said that you need to individualize. That is what I am saying, that it is not a blanket prescription. You have to always outweigh the risk and benefit effects, and you have to fully inform the patients about the harmful effects which she might have. So that is why it is always advised to give the benefit, but looking at the individualization of the patient.
Okay, thank you. We will.
But she is already having at risk of all these.
No, not everybody is having the risk.
Okay, 1 minute over. Thank you. We will discuss the result later on. Let us.
Both of you have done the
Mic.
I think both of you did justice to your topics. And now we have another debate session on yoga versus strength training. What should we prioritize? So we have Dr. Rashmi Vats in favor of yoga and Dr. Saurabh in favor of strength training. So all right, so your time starts now, Dr. Rashmi Vats. Dr. Rashmi is has a current affiliation with Director Guru Kripa Nursing Home. She is Joint Secretary RMS, Executive Member of ROGS, Executive Member of IMS. All right, start.
Thank you, Chairpersons.
Time, please. Audio visual.